that, I would like to turn it over to Tom Walton. Tom is a member of our board, so we're excited to have him, several other board members, and additional people today. So we are going to be talking about fostering health engagement in food pantry populations. We're excited to have 4 panelists with us today. We will have Katie from God's Pantry, Barbara from the University of Louisville, Brooke from the University of Kentucky, and Barry from the Mary E. Martin Diabetes Center of Excellence. So with that, I would like to turn it over to you, Tom.
Thank you. I need to share my screen. Sorry about that. Well, that's not working, so I'll talk you through it. So basically what we're going to talk about today is our friends at the Department of Public Health have told us that in Kentucky we have 632,700 people with diabetes, either diagnosed or undiagnosed. 1.1 million people with prediabetes, either diagnosed or undiagnosed, and we have about a $5.6 billion spend for people with diabetes. So for us to eradicate diabetes, we're going to take what I call a constellation of approaches, both provider-based, community-based, academic-based. And so that's really how we assembled today's panel. And to begin the panel presentation, we're going to talk with Katie Landon. There we go. So this is the constellation of approaches that I was talking about. And you can see this is based on Public Health 3.0, where we talk about traditional interventions, innovative, and also community-based programs. So Katie, you're up.
Okay, everybody, I'm going to share my screen so you can see my PowerPoint. Okay, I think that's up there for everyone, and I hope everyone can hear me all right. If anyone wants to give me a thumbs up, that would be great. Okay, I got it. 1 thumbs up. I'm good. Hey, everyone. My name is Katie Landon. I work at God's Pantry Food Bank as the Youth Services and Nutrition Manager. And today I want to talk a little bit about food insecurity and sort of how that relates to people who are struggling with diabetes and people who are also using food pantries. So have some objectives up there. Hopefully we'll touch on all of those. I also realize that not everyone is familiar with what food banks and food pantries do, so we'll do a brief overview of that. First off, a little definition here for you. Food insecurity in the U.S., the USDA works a lot with that, and they call this people who are lacking access at least some of the time to enough food for an active, healthy life. The estimate in 2018 was that 11% of households were food insecure. I'm sure right now that number is much higher due to COVID-19. So that's just a snapshot in time. I would estimate, again, that those are higher. If you want to look at data in your state or region, there is a great website called Map the Meal Gap, and this is provided by Feeding America. We don't quite have time to explore this website, so that is something fun that you can do on your own. I gave you the link down there. Map the Meal Gap goes into county level data. So you could go into your county, you could figure out how many people are food insecure and what percentage. So that's a really neat way to have that information and to sort of justify a program if you're working with one. So definitely check that out on your own. I do want to mention Feeding America for a minute as well, because that is our national partner that we work with. God's Pantry Food Bank is in a network of about 200 food banks. And so we're assigned a service area, and we also have operational standards that we follow based on Feeding America guidelines. This slide has some of the food resources in Kentucky. So Feeding Kentucky is the network that we work with. There are 7 food banks in Kentucky. So everyone on the call, if you're in Kentucky, you have a food bank that represents your region. It may not be God's Pantry. We have 50 out of 120 counties, which is still a lot. but there is someone that covers your area. To show you the scope of what a food bank does, God's Pantry was able to distribute almost 40 million pounds of food in fiscal year 19, and we did about 13 million pounds of produce. So this is a pretty large scale operation. We estimate that about 1 in 7 Kentuckians receive service from a Feeding America food bank or partner agency. So a lot of the folks that have diabetes are probably also getting food from a food bank. Here's a little map for you. God's Pantry Food Bank is in that turquoise color. So we cover a lot of the counties in Kentucky, but there are definitely partnership opportunities if you do not live or work in that turquoise area. So definitely check out the food bank that is closest to you. And I just want to mention kind of the difference between a food bank and a food pantry. The food pantries are usually smaller operations, sometimes volunteer run. It could be a food pantry, soup kitchen. Those are folks that are giving out the food directly to clients. Food banks are usually the folks who are distributing the food. We collect food from the USDA, from different farms, manufacturers. That's how we get our food in. And then we distribute it to those member agencies. So again, those food pantries, the folks that are working directly with clients or recipients. And we estimate we have about 300 member agencies that work with God's Pantry Food Bank in our 50 counties. There's the slide I was looking for. I jumbled my slides up, but that is the definition of the partner agency. So again, we work with a lot of nonprofits that are volunteer run, that are providing food and groceries directly to folks in need. And now probably the thing that you're most interested in, we do have some data from a hunger study that we were able to complete in our region. And we did this in 2014. We were hopeful to do it again in 2020, but that hasn't quite happened for some reason. So we're gonna work on getting some newer data soon. But this was a survey of 162 partner agencies in our service area, and staff members actually went out and did in-person interviews, and then we provided all that information to Feeding America, so they were able to get information from all 200 food banks about what was going on nationwide. Okay, and this slide, we usually call these our tough choices questions. We try to ask these when we do a survey. But you could call them spending trade-offs as well. And so I think it's good to think about these in relation to someone who is managing a chronic condition, how this could affect their adherence to medications, to appointments and follow-ups. So we found that 74% of households were choosing to pay between utilities and food. 68% of households chose between transportation and food. 74% chose between medical care and food. And 56% chose between housing and food. So if you think about that with having to get to appointments, if you don't have gas money or you don't have transportation, how are you getting to these appointments? So those are really interesting to think about when you think about medical care and diabetes care. And then this slide goes through coping strategies. We ask folks if they had to use any of these strategies. Some of them are, I would say, beneficial. Receiving help from family and friends could be a good thing. Having that support network, growing food in a garden, that's great. But we also had a lot of people, 90% of people were purchasing food that they knew was unhealthy, but they had to because it was inexpensive. We also had people report that they were selling or pawning personal property or watering down food and drinks to make their food budget stretch for the month. So that's interesting to think about. Ways that people are coping with food insecurity. And then probably most interesting for this group, we also asked some health questions, and we did ask this by household. So we had 43% of households that we surveyed had at least one member that had diabetes, compared to 33% at the Feeding America level. Then we had 70% that had at least one member with high blood pressure. And then 73% of people just reported that their health was fair or poor. So I think the population of people that are struggling with food insecurity has a big overlap with folks that have diabetes. So I see a lot of potential for partnerships here. What we're doing as a food bank right now, we have started providing food boxes at some of our healthcare partners. So the Lexington VA Hospital has been our first partner in that. We also have added a SNAP outreach coordinator position to help people access more food dollars and help walk people through that application process. We also have a project going, we're calling it Service Insights, but it's basically a database that we're trying to connect all those food pantries together because sometimes our network is a little more decentralized than we would like. So we're trying to get everyone on the same platform. And then we know that a lot of our partner agencies may already be pairing up with some of you folks that are on the call, local health departments or other health focused groups. So there could already be partnerships in the works. We just may not be aware of them. And I put a few just kind of brainstorming ideas of ways that we could connect. I think having testing booths or health fairs might be something that's already happening, but that's an opportunity. Funding opportunities to get either equipment or specific foods at food pantries. So getting more healthful options in there. Having a research study based around that. Some other folks in our Feeding America network have already done that. So I think that could be a neat partnership opportunity. Any opportunities to educate not only the recipients, but the staff and volunteers at food pantries. And I think there may be a lot of people in this population that are not getting reached by traditional healthcare because they don't have the resources to go to the doctor or go to the health department. So I think we have a group of folks that aren't getting the care that they need, and we have access to that. So I'm interested to see other ways that people are connecting already with food pantries or ways that people might have brainstormed that we could connect. So that is the end of my slide deck. So I'm going to stop sharing.
All right. Well, thank you, Katie. And Barry, have you joined us yet? Oh, there you are.
Yeah. Yeah, actually, Dr. Jones and I are here.
Hey, guys.
Can you hear me?
We can.
Okay. So, Dr. Jones is our medical director at Primary Care Centers of Eastern Kentucky, and he is also an integral part of our diabetes program as well. Our diabetes program is called the Mary E. Martin Diabetes Center of Excellence. We officially got started with it as a service out of primary care centers, or a part of primary care centers. And we eventually evolved into a nonprofit last year to try to help tap into some resources to help our community a little bit more. And but it's still a very integral part of the overall organization of primary care centers of Eastern Kentucky. I am the CEO of Primary Care Centers, and I'm also the chair of the Diabetes Center as well. Probably about 10 years ago, we saw the need for diabetes care as a very prevailing service in our area. When I started looking for a certified diabetic educator, I've got the licensure from the state, and the majority of them were from I-75 north and west of here, even though the Appalachian region is one of the highest rated for diabetes areas in the country. So when we started trying, we saw that we had services such as ophthalmology, we had a podiatrist, our physicians and providers were doing A1Cs, things of that nature. And, but we really felt like we needed a more comprehensive approach. And that's how we developed this is we look at it more than just nutritional education and education of activities of daily living. And we wrap that into a care coordination model. And as you can see, the services on the screen that we provide, and I'll let Dr. Jones works really hand in hand more with the Diabetes Center. I'll let him explain the services.
Yeah, I mean, we essentially have some people that are care managers, kind of like Barry said, and we try to make sure that we check everything off this list, whether it's their digital retinal screening, which we have the retinal screeners over in the clinic. We have some that are handheld. We have one that's stationary. We have a foot care room to take care of their feet, check on that. You know, of course, diabetic ulcers are probably just soft too. Husband and wife both have an ulcer on their foot. You know, that's something that this care manager, they do the foot exams for us. We review, we look at their feet, and, you know, we try to make sure these things are taken care of, and we link them to care with podiatry or wound care or whatever needs to be done. And then they also do the counseling. Since we're doing since we have the CDE, they do counseling on diet, exercise. They help them with carb counting when they're doing their insulin injections. We do insulin pumps. Again, carb counting and all that's important. We're partnered with Medtronic. They do insulin pumps. So we have a Medtronic nurse that usually comes out once a week. And we try to keep our pump patients with her when she's here, but we manage the pump in between when she's not here. So there's just a kind of a wide variety of things we do. And where we do the inpatient care, so we have an inpatient service. You know, when we have these complications from diabetes, we take care of them when they're in the hospital too. I just had one with a diabetic ulcer that turned into osteomyelitis, and, you know, we're taking care of her through the whole ordeal. So.
And we have an in-house pharmacy that also does DME. So we're able to do diabetic shoe fitting. And one of the unique services we offer is we do the diabetic pedicures. And not very many people really want to do them or provides that service because it's a pretty difficult task. We have probably about 1,500 patients in our program. We cover a wide variety of counties. They come from various counties. Our diabetes program, we try to take care of the patient specifically for their diabetes services. So we have some patients that come from other providers other than primary care centers, and we make sure that we get them back to wherever they've been referred to, because we don't want to seem like we're trying to capture their patients for their day-to-day stuff. We try to specialize in the diabetes part.
And we are having some specialists that are sending us their patients. I had an orthopedic surgeon send me a patient yesterday. He's trying to prep for orthopedic spine surgery. Said the guy had an A1C of 9 on no medicines. So, you know, that's the kind of stuff we get from pretty much, you know, not just primary care providers that are having difficulty controlling their diabetes, but from specialists, because they've learned to kind of trust us to help them get these glucoses under control so they can do surgery, do procedures.
And as you see, our outcome goals, of course, improve quality of care. I feel like that we definitely increase compliance, because for a diabetic patient, typically, you know, they go to their primary care provider, they'll get their A1Cs and their hemoglobin and stuff checked, and then they may have the results before they leave, or they may have to be called back. Here, they will have the results before they leave. We can help take care of that. They won't have to worry about changing their medicine when they leave. We also, while they're here, we try to get them to get their feet checked, get their eyes checked. We have dentistry on site. We have behavioral health on site. So we try to get better compliance because it's kind of a one-stop shop. So we feel like we do have kind of an advantage in that regards. We want to improve their well-being so they can live a better quality of life. On the next screen, we'll have some evidence-based care. As you can see, before with pre-intervention, our A1C of over 7 is 25%, and in post, it's 20%. And then for the A1Cs of 7 to 8.9, it's 41, and post-intervention, it's 50%. So you can see that us interacting with the care managers and with the providers being more emphasizing to follow up with the care managers, we're having an impact. As far as cost-wise, we all know that it will be a little while before we'll see the cost effectiveness come into play. And if you go back one time, yeah, reduced healthcare and improved healthcare experience. So,
yeah, I mean, I think being under one roof is the big thing. When you go in and it's just one stop, it's really hard to get these patients to comply, do everything that they need to do. And then it's a financial burden on them too. I mean, we have kind of a, economic poor area. So most of these patients are on Medicaid, so they can't afford to go from one place to another place for testing, or here to the foot care, here to the podiatry. So the fact that it's all in one building, and a lot of times we'll do it all in one visit, that really helps them out.
it really helped our eye exam quality indicators by having our own cameras on site. And we actually have a retinologist from UK that reads those for us. So I think that's a pretty good service for our patients.
Yeah, and it was the case that if you didn't have an eye exam on the chart, even if they had went somewhere else and had it, if you couldn't get the other provider, the ophthalmologist, to send you the report, you didn't get any quality measures met for that. Right. So the fact that we have a screener and we have done an eye exam here, that helps a lot with the quality numbers.
That's great, Barry and Dr. Jones. I would like to say that we can ask questions in the chat, and I'm seeing that Pat has, already identifying some partnership opportunities. So again, that was one of our goals of having these different organizations talking with others, look for both insights and partnership opportunities. And so next we have Brooke Hudspeth from UK and Kroger. Good, take it away, Brooke.
Hi, everyone. Thank you for having me. It's an honor to be here speaking with these other experts on this panel. So I'm really excited to get the conversation going and thinking about ways we can collaborate. So I am going to share my screen now. Maybe a thumbs up if we're looking okay there. Okay, so I am going to talk a little bit today specifically about technology and how we've utilized technology with our program to advance prevention. And so I'm going to, I know we just have a short amount of time, so I just want to start off with an overview of our program and then just speak a little bit to how we've taken our program principles and integrated technology to really help us meet our overall goals. Okay, so our program, as Tom mentioned, I am with both the University of Kentucky and Kroger Health, speaking about our Kroger Health Diabetes Prevention Program specifically today. And so I have just recently transitioned over into a larger role with the University of Kentucky College of Pharmacy. I am a pharmacist and a diabetes care and education specialist, still getting also used to that new terminology there and that new title as that name has transitioned over. But the bulk of my career has been spent in community pharmacy, specifically with an emphasis in diabetes care. And so in my role at the University of Kentucky, my primary responsibilities are to help other pharmacies in the communities across the Commonwealth develop and implement similar programs to help improve access to care. So I feel like this flows really nicely from Barry, what you shared as far as the interdisciplinary approach. and working with the entire healthcare team to help improve patient outcomes. And so I'm just going to share a little bit, about how we've done that with our diabetes prevention program. So just kind of as an overview, our diabetes prevention program started back in 2014 as an expansion of our diabetes self-management and education and support program that we had. So we worked at that time with AADE to expand the services that we provided to focus a little bit more on the prevention piece. And as we started to provide that program, it was recognized that there was a need. I'm sure everyone on this call is very well aware also that there is a need for patients to receive education on prevention, because there's a lot that we can do to help decrease those healthcare costs, to improve patient outcomes by focusing on the prevention piece. And it was also recognized that there weren't nearly enough programs to be able to serve patients that were in need, particularly those that had issues with access to care. There were those underserved populations. And so we were able to partner with the American Pharmacists Association Foundation to expand our program even further and really, create an innovative program where we worked in a multidisciplinary approach with pharmacists, dietitians, technicians, as well as our nurse practitioners with our clinics that we partnered with to deliver the National Diabetes Prevention Program, specifically to those priority populations in those underserved areas in the United States. And again, so kind of expanding further than Kentucky. And when we did that expansion and realized that we needed to grow, we also realized that delivering only face-to-face wasn't going to reach everywhere that we needed. And so we had a thought that pharmacies could serve in a role to help kind of bridge that gap. So we knew that the National Diabetes Prevention Program works. We know that there are many Americans who have benefited from the program, but we know that there are several others who just don't have access to a program that works, that need the program. And so our thought was, in conversations with the CDC, was that pharmacies, particularly community pharmacies, are highly accessible healthcare locations for patients. And so many of you may have heard the statistics, maybe not, but it's estimated that about 95% of Americans live within 5 miles of a community pharmacy. And so we know in our community pharmacies across the nation that pharmacists interact with multiple patients on a daily basis. Many of those also we know who are at high risk for diabetes. And so we knew that we could partner with our community pharmacies across the nation to be able to deliver the National Diabetes Prevention Program and help to bridge some of that gap. Even more so in our particular practice setting, in being in a food store pharmacy, that we also had the opportunity to really work with the dietitians that were on our team, as well as our nutrition technicians, who are kind of extensions in our setting. They're extensions of those dietitians, to be able to help patients with a huge component of disease prevention, diabetes disease prevention that we're talking about today, and that's with the nutrition component. And so we felt like we could use this multidisciplinary approach with our spread across the nation to help reach some of those underserved areas. And so this just highlights a little bit of our work that we did with CDC to really develop a guide for community pharmacies to be able to implement and engage with the diabetes prevention program in their practice setting. And so again, this just highlights some of the key principles when we were working with the CDC to determine what our strategy was for delivering the diabetes prevention program across a variety of settings. Again, focusing in specifically on those underserved areas that had been identified, and also delivering care to those priority populations. And so again, just the physical reach of our pharmacies in our practice setting allowed us to reach those underserved areas. But we really recognize that even with that, there are other access issues. And I know we're going to talk about that today. When we think about, and we've already talked about it a little bit, some of those other social determinants that can really impact patient outcomes and patient care. And so we knew we had to expand that reach even further. And so that's where we really shifted our program from solely an in-person delivery modality to more of a combination approach that combined the in-person delivery as well as telehealth through distance learning and online services to really expand those services and help meet patients where they are. And so our model emphasizes, again, that thought of meeting participants where they are. And the interesting thought that we had is that, this is a year-long program in most cases, and sometimes participants may change where they are throughout the course of that year. And I think we've all seen that, not necessarily by our choice or planning, but with COVID-19 and what we faced there. So we've really had to kind of streamline and speed into that distance learning as well as that digital approach when we're thinking about delivery to our patients, as many of our patients had to switch over very quickly due to a circumstance, again, that was beyond all of our control into that delivery modality. And so that is, again, really what makes our program unique. And one of the things that we really want to evaluate by delivering the program is the ability for participants to be able to change their modality throughout based on their needs. And so, initially when we kind of started this way of thinking, it was, okay, let's say, for example, a patient switches jobs in the middle of the year, right? And then, maybe their previous role allowed them to come to in-person classes, cohorts, but once they had that job change in the middle of the year, they no longer had the same availability. And so for them to be able to continue in that program and have that success, they need that ability to kind of transition into one of those digital delivery modalities. On the other hand, maybe a patient, started out in one of those digital approaches, but then decided that, and through help and guidance from their coach with all of this, and they decided that perhaps they do better with that face-to-face accountability and coming in and being with that group and having to be accountable and needing to weigh in person. And so again, those were some of the key program features and ideas that we had when we developed this approach. So this next picture, just for those that are a little more visual learners like myself, just kind of outlines the structure of the program in a schematic here that just really kind of shows how patients can change between the modalities throughout the course of their program involvement. We do have sessions that are provided one-on-one by our pharmacists or our dietitians or nurse practitioners, but the majority of the program is delivered by a pharmacy technician or a nutrition technician who are the certified lifestyle coaches in the program. And throughout our time, we have worked with a few different digital partners, as I said, through the 1705 initiative with CDC, the grant funding and program that we're working on there. We partnered with APHA Foundation. And we've worked with them and various digital partners. We've been working for the past several months in creating an agreement, a relationship with a new digital partner, Zillion. And so we will begin delivering sessions digitally through that partnership within the next couple of months for patients that are in our program. So again, I know that was a really brief overview, but I'll be glad to answer any questions that you guys have. I've got my contact information here if you have additional questions, and I look forward to the open dialogue as well.
Thank you, Brooke. And now we'll switch over to Dr. Barbara Stetsons from the University of Louisville School of Psychological and Brain Sciences. Dr. Stetson?
Thank you, Tom. I'll see what I can do for sharing my screen here. Goodness, I was hoping. Let's see. How is that? Can folks see my screen?
No.
No? Okay. That is a surprise, so let me try it again.
There we go.
Yes? Okay. Terrific. Okay, I think we have liftoff. Yes, Tom?
It's great. Thank you.
Terrific. Well, thanks for having me, everybody. Today, I'm going to be providing the perspective from the field of health psychology. What I'd like to do is have us think about approaches for achieving engagement with people when we want to be able to implement programs at individual level or a group level or even a community level. So to give you a background of why a psychologist would be talking about that is that I'm in a subfield of interdisciplinary work called behavioral medicine. So I'm a psychology professor at U of L. I was in the medical school for a number of years, seeing patients and teaching. Saw Terry Gerke when I was there, Beth Ackerman, who I know is on this call, working in the Department of Medicine. I went over to the Belknap campus in a traditional role in 2002, so I wear multiple hats. My research lab studies health behavior change, and it's the health psychology provides psychology perspectives within this interdisciplinary field of behavioral medicine. And so our focus is thinking about chronic disease prevention and reducing risk in people who already have chronic disease, and in particular thinking about diabetes. And so what I'd like to do today is share those perspectives, combining working in medicine and psychology in this larger field of health psychology to think about models that you might find useful if you would like to design programs thinking about engagement aimed in a multi-pronged way at individuals, their families, and their communities. So I'd like to tell you a little bit about some of the research that we do in my lab, some published research and some models that have been used in this field of behavioral medicine. The researchers have identified a number of barriers to helping people to change and engage across a variety of levels. And I'm hoping that learning about that will help you in your own work and provide some examples of how it's really not a one-size-fits-all approach that seems to work best if you want to engage people and implement programs. It really depends on the context in which people are operating, since people, of course, with diabetes don't operate in a vacuum. I'd like to share a couple of successful community programs that seem to be successful in terms of having an impact across a variety of levels, and then summarize some takeaways. So if there's one thing that I'd like you to take away from what I have to say today, it's that it's really helpful to view diabetes as part of a system, a multi-layered system. So I have been a member of AADE, formerly AADE, for a period of time, and been very interested in diabetes self-management and how that works psychologically, behaviorally. How can we get people to manage their diabetes? And what I've learned over the years is that the most effective way of conceptualizing this is to think about how self-management takes place in the context of people's homes, their families, their neighborhoods, the community. And each layer of interactions can play a role in helping or hindering efforts to manage diabetes. And really the same approach applies to thinking about prevention. So if we're going to step back and think about how to get patients to show up at a clinic, how to get people to eat their fruits and vegetables, we really need to step back and think about the larger systems. How can we as a community or a healthcare system or providers share the load? And so I would like to suggest that we view diabetes prevention and risk reduction efforts within this perspective, this ecological perspective. This figure here is a model, an ecological model, thinking about how health is impacted from the population level, where you reach the greatest number of people, to the individual level. So if you take a look here at the base of this pyramid, we see that we can have great reach if we are able to address socioeconomic factors. So, as we all are seeing right now with the COVID-19 pandemic, we're starting to see huge disparities in outcomes related to socioeconomic factors. And research suggests that education, poverty, history of deprivation, exposures have lifelong impacts. So exposure to trauma and deprivation in childhood seems to offer difficulties throughout a person's lifestyle. There can be important factors that mediate that, but that seems to be important. And by addressing those socioeconomic factors, we can really diminish health disparities, right? We can also change the environmental context so that when people move forward in their day-to-day lives, they're by default engaging in healthy behaviors. They have clean water to drink, they're not at risk for cholera, the roads are safe. We can offer preventive interventions like immunizations, but often people think about health interventions in diabetes at the top two levels, at the clinical intervention level, thinking about going to the doctor, seeing your health provider, but we know that some people don't show up at the health provider's office. And we also know that some health providers are better at communicating with their patients than others. Sometimes it's hard to have empathy with someone who is different from you are, and that's a two-way street with providers and the people that they see. And providers may not even be aware of the DPP to make a referral. They may not be aware of DSME programs, or they may be worried about losing revenue if they send somebody to a specialist. All those sorts of things can be important. And then, of course, individually, one size fits all for education and counseling does not seem to work. There's several decades of research, for example, on HIV risk reduction and prevention, showing that interventions that you would use with young urban girls to get them to use condoms, for example, is vastly different than what you would use for an older adult in a rural setting. So things like age and gender and resources make a big difference, and that's certainly the case for diabetes. This figure also is from a published study thinking about how things that can impact care and prevention really are all important to consider together. For example, it could be that within systems, people don't have adequate reimbursement issues. There aren't providers in the area. They may not even have access to healthy foods. They may not have facilities that are nearby. And again, as I mentioned before, there can be provider barriers, such as just being concerned about sending patients to specialists, and so on. And of course, cultural issues can really overlap with family issues. And individually, if someone is depressed, which is something that has high rates in diabetes, if they don't have a lot of family support, that can really impede engagement and adherence. And some of these barriers really can vary across age groups in a variety of ways. So what I like to do is think about this issue of prevention and risk reduction in diabetes from this perspective, and think about a couple of populations. One of the things that we know in terms of reaching people with type 2 diabetes is that engagement is pretty poor in young adults, especially those under 40. They may not show up for care. They may not perceive that they need behavior change at that point in their lives for a variety of reasons. We also have a rapidly aging population that has accelerated needs. And then many people are very isolated in their communities from resources, and that could be in both urban settings and in rural settings. And the ecological model can be helpful in terms of thinking about how to reach out to those different populations. One of the things that we've been looking at in my research lab at U of L with my graduate students and interdisciplinary colleagues is thinking about young adults who might be at risk for diabetes and what is driving them with regard to their health. So we did a study with around 100 young adults who were at risk for diabetes, who had either a first degree or second degree biological relative with diabetes, who were sedentary. And we asked them quite a bit of information about their living situation, their environment, their knowledge, their perceived risk. And what we found was that they had okay knowledge about risk factors for diabetes, but it didn't necessarily affect their behavior. They were regular fast food eaters, partly because it's quick, it's cheap, they like it, it's what their peers eat. Very few fruits and vegetables that were eaten, particularly for males. The majority of them were overweight or obese. When we did step tests to look at functional fitness, I was really very surprised at the poor fitness levels. Very minimal preventive care. Most of them don't know what their blood pressure is. They might know their weight. They might go to the doctor for birth control. Importantly, their personal perceived risk for developing diabetes is low overall, despite the fact that behaviorally and from a family history perspective, they are at risk. So for young adults, in intervention, education might not be adequate. They know the risk factors, but if they don't perceive themselves to be at risk, then that is the area that is potentially important for intervention. Also, we've recently started to look at how diet and physical activity vary with sleep patterns in our young adult populations in general at U of L. And we think this is a useful population to study, excuse me, because we draw from a catchment area that's both rural and urban. The average age is around 20. One of the things that we've learned is that sleep is minimal, that nearly 90% use technology in bed every night, usually an iPhones. And using social media in particular is the thing that they're doing in bed. So any of you who have young adult children are probably aware of this, that almost every day, with the exception of Saturday night, they're in bed with the lights out on social media, and the majority of them are using it to keep up socially. If you're thinking about campaigns to promote health behavior in young adults, it's using insulin. And so that can be an important motivator for adults, older adults, to seek out diabetes care. Another thing that I would like to mention is a couple of studies that aren't in my lab that show how the ecological framework can be helpful for developing successful interventions. This slide is from a study that was conducted in Nashville with Vanderbilt and Meharry Medical School. And the goal is to increase fresh fruit and vegetable intake, more whole wheat bread and low-fat milk in low-income areas. And I saw somebody had a question about how do you get people to eat fruits and vegetables. What they did was they identified food deserts in Nashville where people might not necessarily have transportation out of the neighborhood, and there weren't large grocery stores. And then they identified corner stores in those food deserts that weren't primarily focused on alcohol sales. They had a proprietor who was interested in promoting a healthy diet, and the corner store was somehow near residential housing or public housing and would be likely to get foot traffic. And then that yielded 5 stores with at least 1 store in each of the food deserts. And what they did then was they developed a campaign based on stakeholders in the community, based on their knowledge, attitudes, and experiences. So they didn't assume a one-size-fits-all approach, and they targeted store owners, the neighbors, ministers in the neighborhood churches, community organizations, and a variety of places like that. And one of the things that they learned is that the people in the neighborhoods had very different perspectives about barriers and what they were looking for in corner stores. So the store owners were very concerned about crime in the neighborhood and not knowing where to get healthy foods and not thinking that people would buy them. The neighbors were concerned and wanted to bring the families into the stores. They were concerned about poor quality produce, and they didn't necessarily trust the store owners, but they trusted the clergy. And the service organizations wanted to help out, but they weren't sure what to do. And so their campaign put all this information together, and what they did was they educated the store owners about product placement, how to buy healthy food, how to put fruits and vegetables on a cart outside the store. They used the ministers to get the word out, and then they did a lot of branding in key places that were important to neighbors. And it was an effective program, but there was a need for sustainability after funding ran out, which is often a problem with these kinds of interventions. The last thing that I'll mention in terms of studies is that there are organizations of farmers markets that have started to gather data on the efficacy of getting communities to eat more fruits and vegetables by promoting community collaboration and engagement. And there's data in a number of areas in the US. So in Austin, they have found that if you can place farm stands adjacent to community sites and community centers that are valued in neighborhoods, that you can get people to eat more fruits and vegetables as opposed to using the corner store approach. In rural areas in South Carolina, they were able to increase fruit and vegetable intakes by putting farmers markets at health centers. And in LA, they emphasized community connections at farmers markets, and that seemed to be effective for getting people to want to attend the farmers markets. So in terms of takeaways from my perspective as a health psychologist working with the ecological model, is that, if you want to really work to engage individuals and families and communities, you really need to think about influences across system levels, and that perspectives vary quite a bit across populations. And so it's really important to consider stakeholders, and really multidisciplinary approaches are the way to maximize impact and engagement. So collaborating across places like food banks, primary care centers, pharmacies, and bringing different disciplines together is a great way to have that reach.
Okay, well, thank you, Barbara. And Merit has been monitoring the chat box. Mm-hmm. She's going to be asking each of the presenters questions. And then I should also say, presenters, you can ask one another questions too. I mean, this is just very fascinating that these 4 very effective approaches. So Merit?
Okay. Tom, do we want to start maybe with the presenters asking each other some questions?
Yeah, why don't we start? And Katie, do you have any questions for your fellow presenters?
Hey, can you guys hear me?
You can.
Great. I was wanting to ask Barry something about the Center for Diabetes Excellence. I'm not as familiar with that, so I was kind of wondering what a typical visit would look like for somebody, because it sounds like they get a lot of different interactions with folks. I didn't know if you could go through that a little bit more for me.
Sure. A lot of times we'll make it part of just their regular medical visit. So if they have a follow-up with their medical doctor and they're here just to see me for their diabetes medication adjustments and things like that, a lot of times we'll have one of the care managers come in. If they need an eye exam or a foot exam, they actually go through and look at all the providers' visits for the day, see who's diabetic, and see what their care gaps are. What are they missing, whether it's a foot or an eye exam. And then we usually talk to the patients, or they go in and talk to them about scheduling a diabetic pedicure. Sometimes we do it the same day. We've done it a couple of times, same day. It takes about an hour to go through the pedicure and get the water and everything, because we have a really nice pedicure chair, so it takes some time to set up. But most of the patients will wait for it, especially if, their toenails and their feet are in pretty rough shape, and most of them are. So a lot of times we try to integrate it into whoever's flowing through these doors just naturally. We have the care manager catch them and try to make sure that we hit all these quality measures and make sure they're taken care of. So if they need something, with me as a provider, if I'm going to start somebody on an injection, they've never had an injection, the care manager will talk them through how to give the injection, how it works. There's all these different pens now as far as Trulicity, Bydureon, all these different medicines. So they'll actually demonstrate the injection, show them how, and they'll follow up with them if they have any questions on it. So we really try to baby them.
That's amazing. I love that everything's under one roof, and I think a lot of us want to sign up for a pedicure now. I don't know if you have any open spots.
Never. It's always booked.
So Barry or Dr. Jones, do you have any questions for the other panelists?
I don't think I have anything.
No, I don't think so.
Okay. Brooke?
Yeah, I feel like everyone's presentations were so enlightening. So I'm sure I'll have lots of questions. I'll be utilizing that contact information to touch base with you guys for lots of other questions too. But I'll just try to be brief to open it up for the rest of our audience. But Barry and Dr. Jones, I was really intrigued by the also inclusion of a pharmacy in your system as well. So I'm just curious. I know you mentioned DME, but how is your relationship with your pharmacist? And do you see that as a benefit for management of your diabetes patients as well?
Oh yeah, all the time, especially now that the DME is picked up. I don't do everything perfect, especially when I'm busy. So the DME is a little bit tougher because of Medicare requirements. And they're different. I think Medicare is a little bit different. So if somebody needs diabetic shoes and I'm in a hurry and I write the shoes out and give it to them, I'm usually missing something. They need the diagnosis code or my NPI, and it's real easy and convenient when somebody from the pharmacy walks right back over here and makes me correct it on the spot. So there's no delay in their shoes or their medicines for that matter. They usually touch base with me immediately and we fix whatever I have done incorrectly.
It's a good checks and balance.
Sure.
Okay.
Thank you.
And Barbara, any questions for the fellow panelists?
Yes. Katie, I was really interested in the idea of food bank having broad outreach in communities and with families. And I wondered if there were any mobile approaches within the food bank with God's Pantry that you have in Lexington, reaching out beyond the physical space of the food bank, and how that might work in terms of community contacts.
Yeah, so in Lexington, we try to take the food to folks in the community. So we do a couple different distributions for our seniors, where we go into a neighborhood and we set up at a park or school, or whoever will let us set up there. Churches are often our partners as well. So we're out in the community a lot. And then we have 4 different pantry locations that are physical locations that have pretty regular visitors. So, and then we also go out in our communities with like a mobile pantry distribution. So we'll take a semi truck out to a place that maybe doesn't have a food pantry, doesn't have a grocery store, and kind of become a pantry for the day. So we'll try to go to where people are.
That's an interesting theme that's come up for several speakers, is to go where people are. And I think that can be taken, you know, literally in terms of physical space, but also, you know, I hear people talking about what their needs are and being flexible. And that's really neat.
Yeah. So I want to ask Brooke about the nutrition techs, and I think you alluded to them being lifestyle coaches, but I find that a really fascinating concept. And then Mayor will ask questions from the chat box.
Yeah, sure, Tom. So we have kind of a unique approach. So when we were developing the larger scale implementation of our DPP program, we recognized that we probably, you know, from a large scale model, business model too, that we needed to look at utilizing our other associates and workforce that could practice at the top of their license. So we started to look at pharmacy technicians, and then we were introduced to a new role in our setting with nutrition technicians. And so again, these nutrition technicians are kind of extensions of our dietitian team. So currently our dietitian team, we have in select locations, we do have RDs who are inside and embedded within the grocery store setting, but primarily our dietitian team works in a telehealth capacity. And so our nutrition technicians are the physical presence within our stores to help patients make those healthy food selections, to serve as coaches in our diabetes prevention program, just to really help guide those participants or just general shoppers that are in different Kroger family of stores throughout the different locations where our nutrition technicians are located. So they'll do cooking demos or have healthy recipes or help patients to do a grocery store tour, for example, for specific disease state management nutrition recommendations. And so it's been really nice to have them in their role. We are looking at that model right now with our dietitian team and looking at how do we expand that and how do we really utilize those dietitian and nutrition technician services to again focus on that nutrition component of disease management and prevention.
Here.
Okay. I'll do my best. I think I'm going to start at the top, and I've kind of compiled the list and combined where I could. So I believe the first couple of questions are for Katie. What efforts are made to assure people living with diabetes get plenty of fruits and vegetables and not so much in the way of the high carb foods?
Okay, so I think this is a work in progress for the Charitable Food Network. So I want to say that our food bank tries to make a commitment of about 1/3 of our poundage coming out in produce, because we know produce is that really good, healthy stuff for people to get. And then we have certain programs that we have more control of the food in. So the USDA programs usually have a set type of food or amount of food that they give us, and that's like the commodity supplemental food program. They determine what folks get in those boxes, so that is really good because we can control the types of food. Some of the other things, some of the pantries let people choose what they would like, so that becomes a little tougher. We don't have a specific diabetes friendly box or regimen right now, so I think that's definitely a work in progress or an opportunity.
Okay. And then next question for Katie. Do you have any staff that can or do serve as health ministers?
I'm intrigued by this question because I'm not exactly sure what a health minister would do. I think I'm the only staff member with that is a dietitian or anything like that. We do get dietetic interns regularly, and we have a lot of social work interns, but not as many in the health careers.
Okay, thank you. And before I forget, I'm getting quite a few people will want to check the chat boxes. Pat Ryan with the Bluegrass District Lions Diabetes Project, where they're conducting A1Cs, would love to partner with groups throughout the state, but especially in the surrounding region. So if you'll just scan and read through, he has a great network of people with whom he's working, but he's definitely interested in making more connections. Next question, I believe, is for Barry and Dr. Jones. Is the Mary Martin Center connected with Big Sandy Diabetes Coalition? And again, this is from Pat. He would love to partner with you, I believe. But if you can just explain a little bit about any groups with whom you're connected.
Okay, we're not connected with the Big Sandy Diabetes Coalition. We're located in the Kentucky River Area District. And I think their efforts have kind of come and gone some. And so we really haven't connected with anyone at the Kentucky River Health District in regards with diabetes.
Okay. And what does diabetes support between the visits look like?
A lot of times it's follow phone calls. We check on them again, like if we've instructed somebody on an injection, or the care manager's done carb counting with them, or we've had an issue with our insulin pump. That care manager will call, follow up, make sure things are going okay, or if they need any further explanation, we'll bring them back in if we have to, or if we can do it over the phone, we'll do it over the phone. But a lot of times we continually check back in with those who are having issues. So that's a lot of what care management in between is, just staying connected with them.
It's always a work in progress.
Oh, yes.
Yeah.
Do most of your patients have insurance or Medicaid, and do you accept uninsured?
Yes, most of our patients have insurance. We also have, they used to be called Connects, or Kentucky Connect, or Assisters, that helps patients find resources. So we're very good at helping them find resources if they don't have it. But we also have a sliding scale program for our diabetic patients as well if they do not have insurance, and it's very, very reasonable.
Yeah, almost everybody that comes through the door has insurance, and if they don't, we hook them up with these connectors. We connect them to somebody who's going to get them insurance. Right. And now with the COVID, I mean, just on the side, I had a guy came in the other day, he had no insurance. Said, go in here. He had it in 5-10 minutes with the, I guess, the COVID emergency Medicaid order. So yeah, we just about keep everybody insured. And I think the sliding scale is pretty cheap.
It is.
We do all inclusive. So it's the visit, the labs, everything. It's, I don't know, $30-40 or something.
Yeah, it's not very expensive at all.
That's wonderful. Dr. Jones, what's your area of practice?
Well, that's an interesting question. It's internal medicine, but I definitely have the niche for diabetes, and I learned the ways of the insulin pump early on, and have actually learned the ways of hepatitis C. We kind of tailor ourselves to the area. So, diabetes is huge here, cardiovascular disease, and because of the drug epidemic, hepatitis C is a huge part of our patient population anymore either. And it's very interesting when you mix it with diabetes and injections. So that makes it all the more difficult sometimes trying to manage these patients, because there's plenty of overlap.
Definitely.
I'm going to take moderator's prerogative here and ask the last question because we're running out of time. And it actually, Amelia from the Foundation for a Healthy Kentucky asked about the use of the Adverse Childhood Experiences questionnaire in any of your practices. And maybe we could start with Dr. Stetson. And I don't know if you ever have done any studies that link ACEs and chronic conditions.
That's an interesting question. I have not, but I'm a little bit familiar with some of that research, and I know that people are very interested now also in adverse experiences, including things like racism and the experience of microaggressions, which seems to be important and show long-term impacts on health. But also people are really very interested in measuring experiences of resilience. Resilience is something that's measured mostly in children. People are becoming very interested in that as an adult. So to be resilient is to have had a lot of adverse experiences, but somehow have growth from it. And that's being studied in cancer patients. If you think of cancer as a form of trauma and adverse experiences and how some people might psychologically grow. And more people are starting to examine things like flourishing and what flourishing means as opposed to tanking and not doing well. And so it's interesting to look at some of those things together. Feel free to shoot me an email if you want to talk about some of those measures or constructs. I think it's really interesting, important stuff.
Well, I want to thank all of our panelists today for both your time in presenting, but also in the preparation. I did check with the panelists and they are all willing to answer your emails. And so when we send out the slide deck, you'll have their contact information. And with that, I think we'll kick it back to Terry.